get ready to start. So I'm at the nurse's station and I see I have an order here. I have Miss Patricia Green, birthday 2954 with allergies to penicillin. She was admitted for abdominal pain, nausea, vomiting, and she has a possible bowel obstruction. We are putting in a 14 French nasogastric tube. 14 French has to do with the size of the nasogastric tube, just like the Foley catheter does, okay? Then I'm gonna get a stat chest x-ray to confirm the placement of the NG tube. And then when I'm done, I'm gonna set the suction to low intermittent suction, okay? So now I'm gonna go gather my supplies. All of my supplies are clean, dry, intact, and not expired. So I am going to go into the patient's room. Knock, knock, knock. Hi, good morning. My name is Rachel. I'm a student nurse with TCC, and I'm here to place that NG tube that Dr. Lake spoke with you about. It's going to help pull that pressure off your stomach and hopefully lower your pain. And we're hoping that we're able to get your bowels moving again so that you don't have to have surgery. So what the NG tube is it's a small tube that we put down your nose, and it goes all the way into your stomach. I'm going to be asking you several questions to help get you prepped for it. And it's going to be hooked up to the suction on the wall. So you need to be really careful with turning your head. So when you're turning your head, make sure you turn it slowly. If you notice the tube starting to come out, I want you to hold on to it and call us. Don't touch the tape. If the tape starts to come off, give us a call. If you feel like you're having nausea or if you start to vomit, we want you to call us. And then if you do need to get up to go to the bathroom, we will come in and clamp it and help you get up. Do you have any questions? No? Okay, I'm going to don my gloves and clean my table all the way around. All right, I'm gonna wait for that to dry, set my stuff on here. This is a clean procedure, so you don't have to worry about reaching over things like you did. I'm gonna set out all my supplies, all my tools that I'm gonna use. Can you tell me your name and birthday? Patricia Green, 2954. And Ms. Green, what allergies do you have? Penicillin. What happens when you take penicillin? I get a rash all over my body. Are you allergic to tape, adhesive, lubricant, or latex? No. All right, do you have any history of nasal surgeries, gastric bypass surgeries, abdominal surgeries of any kind? No. Okay, I'm gonna raise the head of the bed all the way up here. Are you able to move your head side to side, up and down? Yes. Are you able to swallow? Yes. So I'm gonna raise this bed up pretty high because I want you to be sitting all the way up when I put this in. I'm gonna move your pillow, okay? All right, so I'm thinking about my other questions that I need to ask. Like gastric surgery, move the head, you can sit and swallow. One of the things that I do want to tell you, we're going to set up like a little distress signal here in case you're feeling like you're having, that you're going to vomit, that you all of a sudden can't breathe, things like that. Set their hand out, that way I have a place to put the cup. I want you to raise your left hand up. You understand? Yes. Okay. I'm going to hand hygiene again. So I'm also going to ask you to take your finger and occlude one of your nostrils and sniff. If you touch your own nostril, you must hand sanitize afterwards. If you touch your nostril and then touch your pen is dirty, okay? If you're wearing gloves, you gotta take your gloves off, okay? Okay, now let's do it on the other side. Does one side seem clearer than the other one? Yes, my right side. Make it be the side that you're standing on, okay? All right, I'm just gonna take a quick look up your nostril. All right, so when I'm doing this, there's a chance that they might be breathing on this, so I'm not gonna put it back in my pocket. Where do I put it? On the table, so I can clean it later, okay? All right, so now I am going to put on my stethoscope. First, I'm going to listen to the breath sounds in 6 positions. I'm doing this so I know what their current lung sounds sound like. After I put in the NG tube, I'm going to repeat that assessment to make sure that there's not any differences. That might give me a clue that I might have accidentally put it down into their trachea instead of down into their esophagus, okay? May I pull down your covers and listen to your stomach? This person has a bowel obstruction. For the purposes of this checkoff, this person is going to have absent bowel sounds. How do I know that the person has absent bowel sounds? What do I do?
Listen for like a full 5 minutes.
Where?
In each quadrant.
Yes. I'm listening for 5 minutes and hear no bowel sounds. I'm listening for 5 minutes and hear no bowel sounds. I'm listening for 5 minutes and hear no bowel sounds. I'm listening for 5 minutes and hear no bowel sounds. Okay? In a real life person, depending on where the blockage is, most likely, like, you'll probably hear hyperactive bowel sounds further away, like closer to the stomach, and then like a hollow sounding sound. That's what absent bowel sounds sound like. It just sounds like, that's the only way I know how to describe it. It sounds like it's hollow. But for purposes of this checkoff, that's how it's going to be. We're going to use this again. This part's touched the patient. This part's touching me. I'm going to set it in such a way that when I put it back in my ears, I don't have to re-clean it. Okay? I'm going to lower this so you guys can see. Okay, now I'm going to palpate. Does this hurt? Yes, please don't do that. You're killing me. I'm just about to die. Okay? I'm going to palpate all 4 corners. Yes, they noted tenderness with the palpation. Okay? How am I doing?
Good. The only thing is you forgot to teach the client to keep the head of the bed at a 30 degree.
And you know what? And I did that last time too. And that's because when I do it, I always do it at the end. You can do it either way. So yeah, so part of your treatment is that you have to keep the bed no lower than 30 degrees. And at the end, I'm going to put it at 30 degrees so you know what that feels like. And that's as low as the bed can go, even when you're sleeping. You understand? Yes. Thank you. All right. My hand sanitize again after touching the patient. And you can always put on gloves. It's never wrong to put on gloves at any point. If you wanted to do all of that with gloves, you can. I told you guys before, whenever I touch a live patient, I'm always wearing gloves because I don't know what's on their gown. Okay, so I'm going to start to set everything up. I'm going to put this drape on you. It is common, it can be common for people to vomit when you put an NG tube in. And if they're already prone to nausea and vomiting because they have a small bowel obstruction, the chance is even greater. I've done this like twice in real life, but I've set a check on somebody. Normally I just have a towel. All right. Okay, so here's a little emesis basin in case you need to throw up. Here is your water cup. So when I tell you to take a sip of it, you're going to take a sip of it and swallow. I'm going to help advance the tube. This does a couple of things. This helps them to use that muscle action to pull the tube down and help you advance it. Plus, when you're swallowing, your epiglottis closes off your trachea, so you have less of a chance of getting it down into, I said their trachea, yeah, their trachea. So you have less of a chance of getting it down into their lungs, okay? Can you blow your nose for me? Great. So this is set up for my lubricant. So you can just get a piece of paper towel. And then I always have an extra one for taking out the NG tube at the end. Taking it out is not part of the skill, but I'm gonna show you how to do it anyway. And yes, you're actually using lube with your mannequin. It's a lot easier with the NG tube than it is with the Foley top. when you're trying to reuse your Foley catheter. Okay, so again, I'm taking a look at everything. It's all clean, dry, intact, and not expired. You can set stuff in your nice clean emesis basin.
Did you just put the lube just on the chucks?
Say that again?
Did you put the lube just on the chucks? Or?
No, it's on my little piece of paper towel. So I am just gonna double check. I already said it's clean, dry, intact, and not expired. I'm making sure that it's a 14 French, okay, so that I have the right size. There are different uses for NG tubes. It's all in the PowerPoint that's on Canvas that you guys are supposed to look at. I'm gonna go ahead and prepare my tape now. Hopefully you won't live in a world where you have to prepare tape for an NG tube. And you can use either a nasogastric retention device. Again, I have pictures of different ones that are on in the PowerPoint, or you can have the sticker one. When using the sticker one on a real person, use skin prep so that it removes the oils from the skin, or at least an alcohol pad. That's not part of our checkoff. I make my little pants look like this. It makes it a little bit easier to attach it. It's difficult to attach the tape, especially when you're wearing gloves. Make sure that the gloves that you bring fit you well, or so that you know, you don't end up like pulling the glove off, getting it stuck on the glove. I've cleaned all around my table, so I can go ahead and put it right there. If you want to make 2 of them or 3 of them in case you accidentally mess up, because every time I've done it, I've had to go back and get a second piece of tape because I've messed up. You can use either tape. You can use the silk tape. You can use the regular tape that like comes with the IV kit. I'm gonna set them up both ways and we'll just see what happens this time when I try to do it, okay? All right, so the first thing, oh, and I actually need one more piece of tape. So then you also need a piece of tape to mark where the length of your NG tube is. So first I'm gonna measure to see how much NG tube I need. When you open it up, you have this little connector tube. I'm gonna go ahead and take that connector tube out, and I am going to put it on my tubing. So your tubing and the canister is already gonna be set up for you for your checkoff, okay? So I'm just gonna slip this right here behind the patient. So that's ready. So when we measure, get this out of the way, we start at the tip of the nose, we measure to the earlobe, and then to the xiphoid process. Who can tell me what the xiphoid process is?
It's the bottom of the sternum.
The bottom of the sternum. So I'm gonna feel on my mannequin. I'm gonna go about right here, and this is 54 centimeters. I know that because I had you guys keep the one with the numbers on it. See? So it's also important to know because that's gonna be part of your documentation. So you're gonna put a piece of tape on it. Make sure that you put the piece of tape with the top part at the 54. Don't put the bottom piece of the tape up here at the 54, or else it ends up being at 52, okay? So you need to make sure that you place your tape appropriately. This just makes a little flag so that you know how far to insert it. And then I'm gonna curl it around my fingers. I want it to look like this. This is gonna help it go back, if it's like in this hook configuration, it's gonna help it go back down and around into the patient, okay? I'm also going to take my syringe and attach it here. Some people draw up 30 milliliters of air. I've seen that on some of the videos. They do this, one of the old style ways that we used to confirm placement was to push 30 mils of air into the stomach and listen with your stethoscope right here up just below the rib cage, and you could hear the contents bubbling. How do you think your patient might feel having air put in their stomach when they already don't feel well? So we're using an x-ray anyways, and we're gonna look at the stomach contents with this. So I don't do that with a real person. I think that's too mean. Okay. Am I forgetting anything yet? Are we good to go? All right. I'm gonna go ahead and get my lube. Again, not sterile. You can reach over stuff. It's just a clean procedure. One of the things I forgot to say, you have a bunch of little holes right here in your NG tube, and this is how the contents get pulled up. So they get pulled up from several different spots, okay? All right, so I'm gonna have him lean his head back, so extend his neck, and when I get to the back of the oral pharynx, I'm gonna meet some resistance in a live human. At that point, that's when I'm gonna have him tilt his head forward. You have to control his head. So just put your hand back here, extend it, flex it, okay? All right, so I'm gonna put it in, and I just want you to hold up your cup, and I'm gonna tell you when you start to take a sip. So I'm gonna put it in, and what I say in the mannequin, because you're not gonna meet that resistance, I say between 12 and 15 centimeters, say, okay, now lean your head forward. All right, take a sip, and you're gonna put it in, and sometimes that's where you meet resistance on the mannequin. It's not like that on a real person, okay? Take a sip. I'm gonna try to advance it about 2 inches each time. Take a sip. Take a sip. On a person, if you run into problems, it may have rotated once you put it in there, so you may need to pull it out. That'll happen early on, and make sure that it's hook shaped, okay? Take a sip, take a sip. Okay, stop, we're there. In a real person, if I were to let go of this, that NG tube's just gonna slide right out. So if you look on the Evolve video, they have like a second person come in and hold it for them. You don't have a second person to hold it for you. So you need to hold it in place. You want it to be in the center of the nair, and now we're gonna try and see what happens with the tape. Okay, so I'm going to tape it to the nose. I'm gonna turn his head a little bit so you guys can see. If you wanna lower that, you can, Catherine.
It's okay.
Okay, let's see if I can peel this piece of tape off. I ran out of the other tape, and I just have the silk tape. Okay, so when you start to tape it, you can either wrap this flag around so that it's flat, or you can take it off. It's kind of hard to take it off though. I don't suggest doing that. That's gonna make you move the tube too much. And you're gonna wrap the little leg around, and you're gonna go in an under fashion. So you're gonna start going under first. Okay, and once it's taped onto the nose. All right, can you tell me, did you have any discomfort with that? Yes, it burned. On a scale of 0 to 10, what did it feel like? It was a 3. Okay, I'm so sorry. That part's done. The worst is done. The next thing you're gonna do is you're going to aspirate. Whenever you're aspirating, you wanna hold on to the junction between the NG tube and the syringe so that it doesn't accidentally come out. Sometimes stuff starts to, if they're really impacted, stuff will start to go ahead and like start coming down the tube if this comes out. And then all of a sudden you're like, there's, stomach contents everywhere. So you're gonna pull back 30 mils, and then you're gonna say, oh, I see dark green stomach contents, or I see brown stomach contents, or bright green stomach contents. It doesn't matter, you make up one of those colors. Anything you take out, you need to return, because we don't want to turn the pH or upset the pH of the person. At this point, you have a couple of options. You can either call, because the x-ray people are waiting right outside. You can have this still attached and call. You can attach it to here, but not turn on the section. Whatever's gonna make you not turn on the section before you get the x-ray is how I want you to do it, okay? So this is technically clamped, it's not going anywhere. Hey, can you come do the stat x-ray in room 8? Sure, great. They come in, they do the stat x-ray, they see that it's nicely coiled in the middle of the stomach. nicely placed in the middle of the stomach. It all looks good. We can go ahead and use it. How am I doing? Okay. So now at this point, I'm going to grab this. Since I've pulled up stomach contents also, there's going to be green or brown stuff in here. I need to kink it off, take this out, and whenever you're taking something off or moving it, you always want to have a towel or something because there's always the chance stuff is going to come out. And then I'm going to go ahead and attach it. This blue thing is an air vent. This prevents the NG tube, all those little holes, from adhering to the side of the stomach and doing damage to the stomach lining. You never want to occlude this with anything. Nothing's gonna drip out of this, so you don't have to worry about stuff dripping out. And then we're gonna grab our little thing. So go ahead and gently turn your head. Let's figure out where we can, how much play that you need in your NG tube. And then I'm going to attach it to your shoulder here. Okay, I'm going to lower the bed just so you guys can see this NG tube. See the regulator. So the suction regulator over here on the wall has green all the way around to red. So 0 millimeters of mercury all the way around to 300. Low is anywhere in the green. Okay, so what I typically do, but when I first turn it on, I'm going to turn it on regular just to see where it is. Okay, so it was in the green, so that's okay, it's in the right place. If it were over here or over here, I'd turn it down and then turn it off. Okay, having it on regular for that long while you're checking it is okay. Intermittent is just what it sounds like. It's on some and then it's off some. So it's important to also explain to the patient that you're going to hear the machine making noises sometimes, and then other times it's going to be silent. You're going to notice as you move your head, as this turns off and on, that you're going to see the stomach contents kind of move back and forth in the tube. That is okay, and that is completely normal. They sometimes freak out like when it turns off and then all of a sudden a bunch of stomach contents, they see it moving back into their stomach, and that can be very concerning for a patient. Okay, so we let them know that. All right, so I have it on low intermittent wall suction. Oh, look, it's a little high. I'm gonna turn it down just a little bit. So it needs to be in the green area, okay? All right, I'm gonna go ahead and lower the head again so you can see what 30 degrees is. If they're a confused patient, you probably need to lock it. Your patient, Patricia, she's not confused. She knows why she's here. She's not gonna mess with it, okay? All right, do you have any questions or concerns? No? Okay, great. I'm gonna be back in about 15, 20 minutes to recheck you. Just like how you need to check an IV site every time you round on your patient and go into the room, you need to check your NG tube placement. We have a bunch of mucus in our mucous membranes, our nose. Even though the tape and everything looks perfect, you might come in and now it's down at 40 instead of where it's supposed to be at. So you need to check it every time you go in the room to make sure it's still in the right place. This is especially true. It can happen like the longer somebody has an NG tube. That's one of the reasons why I don't like tape. I like I have pictures in the PowerPoint about some different retention systems that we can use. I love them. I think they're awesome. And also, like, they keep confused patients from pulling it out because, like, if they start to pull it, it's very tender. It doesn't hurt them. And it's not like how somebody could, like, pull out a Foley. Like, they're not going to be able to pull it out because it's behind the volar bone, but they're going to stop pulling on it. So. Okay, then I'm going to take all my stuff, Make sure I'm taking off my gloves properly. This is a reminder to everybody. I love that. Reminder to everybody who is having their check off today to take their gloves off the right way. I'm gonna hand hygiene and clean up all my stuff. I'm also gonna clean all of my tools properly and leave the room. Did I miss anything else? No. Okay. Questions? You may turn off the videos now. Or